Welcome everyone for this for today's webinar. We're really excited to have the CDC team with us today. I think we've all learned the importance of the CDC over the past 3 years, the important role that the CDC plays in obviously in a global pandemic. But it's always important to remember that the CDC stands for the Centers for Disease Control and Prevention. And I think what we've learned over the past few years is that you can only control and prevent if you have data. And so today's talk is going to be a lot about data that has been learned in the past 3 years, both on myalgic encephalomyelitis, chronic fatigue syndrome, ME/CFS, and the intersection with long COVID. And so today we're delighted really to have this distinguished team from the CDC. And probably I don't need to have a very long introduction to Dr. Oved Unger, who's the chief of the chronic viral disease branch within the CDC, and has been an expert on not only ME/CFS but also human papillomavirus, which is a topic that we may talk about in a future conversation. Really for today's talk, I think it's important to note that Dr. Unger served as a co-lead of the post-COVID conditions team during the CDC COVID-19 response team to really make sure that the understanding of ME/CFS serves to help address the post-COVID conditions. So we're going to learn a lot today about this intersection. It's really, we've heard a lot about, the CDC not being able to recruit or retain people. I think today we have a phenomenal example of a team, a very strong team. And so, Dr. Unger, congratulations on assembling such a strong team. We're going to have Dr. Cope with us. Dr. Cope is a medical officer at the centers at the CDC. And really in the past 3 years, she has served in many roles as part of the CDC's COVID-19 emergency response, including leading a unit dedicated to the study of post-COVID conditions, or long COVID as we call it. And she now leads the CDC's chronic viral disease branch, which looks at a number of projects related to long COVID. So very, very important experience that Dr. Cope is going to share with us. Also delighted to have Dr. Issa with us. And Dr. Issa is a medical officer with the CDC. She completed her fellowship in pathology and forensic pathology, which of course is very critical to our understanding of ME/CFS and long COVID. And really in her role right now, she's studying ME/CFS more specifically, and again, serving on the COVID-19 emergency response. So I think we see this connection, making sure that what we've known in the past serves us to understand the current situation and the future. So thank you, Dr. Issa, for joining us today. And then we're also going to hear from Dr. Nji. She is a medical epidemiologist at the CDC. And of course, we understand the importance of understanding the epidemiology of these conditions. And she currently provides medical and epidemiological expertise to the post-COVID conditions and ME/CFS. So all three experts that really have been at this important critical junction of long COVID and ME/CFS, and we're delighted to hear more from you today. Dr. Unger, please.
Thank you. Thank you so much. We really appreciate the opportunity to present some of the work of the chronic viral diseases branch that's related to long COVID. And as Oved mentioned, we became involved in long COVID because we anticipated a post-acute infectious outcome similar to ME/CFS was definitely a possibility following SARS-CoV-2 infection. And as the pandemic progressed, we and others recognized the striking similarities between ME/CFS and long COVID, or post-COVID conditions, as the term that CDC uses. So we approached the challenge of long COVID really through the perspective of what we've learned about ME/CFS. And as part of introducing our talks, I'd like to place our work within the context of the government-wide response to long COVID. This is led by the Office of the Assistant Secretary for Health. And CDC is one federal agency addressing long COVID. And within CDC, the chronic viral diseases branch is one group. Those leading the government response recognize the need for agencies to work together to meet the challenges faced by those living with long COVID, and further recognize and welcome the input of those with lived experience of the illness. Based on the questions shared with us prior to the webinar, I thought it may be helpful to share some of CDC's online resources. And I've asked that these links be placed in the chat for you. There's a web page with information on long COVID for the general public. And this includes a section on caring for people with long COVID, as well as guides for patient appointments. There's a separate section for healthcare providers, and the clinical outreach and communication webpage has links to the 4 calls or webinars on post-COVID conditions. The most recent one was addressing children and adolescents presenting with post-COVID conditions. Finally, there's a webpage describing research projects led or supported by CDC. All these links should be provided for you in the chat. And given the availability of the resources describing our current understanding of post-COVID conditions or long COVID, we wanted to take the opportunity to share information on 3 of our public health research projects. While there's additional ongoing work that we'll share at other times, these were selected to give you a sense of the different approaches that are used to address a variety of questions, as well as to introduce you to some of our new young investigators that represent the future of CDC. Nanda Issa, who has been with our program 4 years, will tell you about our school-based active surveillance project. Miriam Nji, who joined our program through the COVID emergency response, will describe what we are learning through standardized medical record review of patients attending post-COVID clinics. And finally, Jennifer Cope, who joined our program a little more than a year ago, will describe our project designed to improve care of patients through educational primary care providers using Project ECHO. So at this time, I'd like to turn it over to Nanda. Thank you.
Thank you all for joining. I'll be presenting on a project that we've been working on about school-based active surveillance of ME/CFS among school children. But before we start, as a disclaimer, the findings and conclusions in the following presentations are those of the authors and do not necessarily represent the official position of the Centers for Disease Control and Prevention. Next slide. Yeah, so I'll be talking about school-based active surveillance, which is also known as SBAS, myalgic encephalomyelitis, chronic fatigue syndrome among school children. Next slide. So to orient you all, here's an outline of what we'll go over. We'll first start by discussing an overview of the project components. And this project, like I said earlier, we'll refer to as SBAS, school-based active surveillance. Then we'll go over the steps in the SBAS process and the key findings of the feasibility assessment, and finally, the applications to school nursing. Next slide. The National Association of School Nurses, also known as NASN or NASN, is well known for its role in leading school health initiatives and has been developing projects to track student health. In September of 2018, the ME/CFS program at CDC funded NASN through a 3-year contract to conduct a pilot of school-based active surveillance of ME/CFS using a nurse-led approach and chronic absenteeism data. This involved educating school nurses on ME/CFS and data collection. We've continued working with them on phase 2, or the expansion phase of this project, which will go on until 2024. Next slide. So why use chronic absenteeism data? Well, chronic absenteeism data had already been chosen by 36 different states as a non-academic measure of school quality and student success as part of the 2015 Every Student Succeeds Act. As it was already being used to identify or flag students with potential academic or health concerns, it made sense to leverage its use. Now, chronic absenteeism is defined as missing more than 10% of a school year, or roughly more than 2 days per month. It's been associated with academic failure, dropout, health inequities, and health issues. Children with ME/CFS often may miss school, and that might be mistaken for school phobia. But unlike those with school phobia, children with ME/CFS are still inactive on weekends and holidays. They may not be able to do their usual hobbies or take part in school activities, which they did before the illness. They may also have problems completing school assignments within the usual time. And this might be a result of problems with thinking or learning or memory caused by the illness. School nurses who are at the front line of primary care and public health can identify those students who are chronically absent or sometimes even trending towards chronic absenteeism in an effort to get them the help they need early on. Next slide. As an overview of the pilot phase of this project, there are three main components. The active surveillance pilot itself was conducted by school nurses at 6 demonstration jurisdictions, the development of an electronic data platform, and the training of school nurses in data collection to build capacity. I'll expand on each of these areas in the next several slides. Next slide. Having school leadership and school nursing leadership support data collection was critical to the success of this pilot phase. This allowed school nurses time to conduct active surveillance focused on identifying students with chronic absenteeism. The pilot sites were chosen in areas where clinicians who had expertise treating patients with ME/CFS. Ultimately, this involved nearly 250 schools in 6 school districts in 4 states, Florida, Massachusetts, Utah, and Michigan. Surveillance activity reports were also delivered as part of this contract. Next slide. NASN performed an environmental scan, which determined that an electronic platform would streamline data collection. They subcontracted with the 3C Institute to develop this platform, which was established as part of the contract with CDC. A report outlining data platform attributes explained data entry, form design, and data management among different school hierarchical levels. They then completed a testing phase of the platform, which included a webinar to train school nurses on how to access the platform and enter data. Finally, they conducted an evaluation of the surveillance system, including the electronic data collection platform. In the box at the bottom of this screen is a screenshot of the data collection platform showing where the school nurses could enter the number of students with chronic conditions shown. They were collecting data already on asthma, seizure disorders, diabetes, and life-threatening allergies. So they leveraged this existing system to add ME/CFS to the track conditions. Next slide. The needs assessment mentioned earlier also found that there was a need for increasing knowledge and awareness of ME/CFS among school nurses. So school nurses need to be trained not only on how to collect data, but also the clinical presentation of ME/CFS. Data coordinators held training events to teach school nurses how to collect data on chronic absenteeism, and several courses were developed to teach them about ME/CFS. Here are some cumulative metrics on the training events since the start of the project in September of 2018 until February of this year, 2023. Among these metrics, NASN featured SFAS or ME/CFS through email and other social media channels, including the NASN Weekly Digest, on over 70 different occasions, and each feature reached about 58,000 people or more. Next slide. So now that we understand the project components, what exactly do the nurses have to do in the school-based active surveillance process? Here's an overview of the entire SFAS process. First, the school nurses track absences and identify those students who are chronically absent. They then find out which students are absent for health reasons. The school nurses will reach out to the student and or their family to determine the reason for absence and may also ask them about symptoms seen in ME/CFS. At this point, they may come to an understanding about which nursing diagnosis they want to use, and at this point, they'll develop a nursing plan. And finally, the school nurses will evaluate the process and share the results with school leadership. Next slide. Now, to break the beginning of that process down a little further into more detail, I'll walk you through this flow chart. As mentioned, the school nurses conduct the surveillance by tracking students who are chronically absent from school, document how many of those students are absent for health reasons, and categorize the health reasons as a diagnosed illness or an undiagnosed illness. If the symptoms include those seen in ME/CFS, the school nurse will contact the student's parents or guardians and refer the student to a provider who is experienced in caring for patients with ME/CFS. They'll continue to follow up with the students and their families to see if a diagnosis of ME/CFS has been made by that healthcare provider. And if a diagnosis is made, it will be reported in that surveillance system. Additionally, as part of the follow-up, school nurses will work with school administrators, teachers, and families to establish accommodations and individualized learning plans for these students. Next slide. As part of this contract, NASN also developed the School Nurse-Led Active Surveillance Manual, which is available on their website and contains information about the process of active surveillance. It also includes, among many other things, information about ME/CFS in the introduction. Next slide. So how did we disseminate the lessons learned from the SFAS project? Well, there have been presentations at the NASN annual conference, but to reach an even larger audience, we published an article in the Journal of School Nursing titled Feasibility Assessment of a School-Based Nurse-Led Approach Using Chronic Absenteeism to Establish the School-Based Active Surveillance Process. School nurses found that the SFAS process helped them effectively identify students at risk for undiagnosed conditions. Next slide. Here's a table from the article. 2,301 chronic absences were counted over the 3-year period, with 28% of them due to a health condition. Mental health, family concerns, asthma, and respiratory reasons were the main reasons for the students' absences. School nurses referred 4 students for ME/CFS-related symptoms to ME/CFS specialists, but ultimately other probable causes, not ME/CFS, were identified. The key findings that we'd like to highlight from this feasibility assessment include the following. Next slide. For one, the process did successfully identify complex student health needs, including the potential to identify undiagnosed ME/CFS. The process highlighted how school nurses are key members of student health team, and they help bridge the school and the community. It underscored that there is a need for us to continue this data-driven approach, which started with the Every Student Counts effort. And finally, it emphasized the need for increasing knowledge and awareness of ME/CFS among school nurses. Next slide. So what are the next steps and how can we apply what we learned to the school nursing practice? Well, phase 2 is currently ongoing, and this expansion phase, we include more school districts and states over the course of the next 3-year contract. Since this pilot phase occurred as the COVID-19 pandemic was ongoing, there will be a need to improve our understanding of similarities of long COVID and ME/CFS and see if the lessons learned here can be used to track long COVID among children. Because the pilot was successful, NASN can work on integrating the data entry at the school level of newly piloted data elements with NASN's National School Health Dataset, Every Student Counts. Next slide, And finally, we can use those lessons learned from active surveillance process using ME/CFS as an example to improve the identification, access to care, and health and academic outcomes for children with chronic conditions. Thank you.
So today I'll be talking about a project CDC has been working on to characterize post-COVID conditions among patients who attended 3 post-COVID clinics in the United States. Next slide, please. Throughout this presentation, I'll follow this outline. Next slide. And firstly, some background. Next slide. So thanks to people who experienced COVID early on and alerted scientists, we now know that COVID can lead to new onset, sometimes worsening or persistent symptoms that we call post-COVID conditions, PCC for short, or long COVID. Long COVID turned out to be puzzling conditions that affect multiple organ systems, and symptoms can range from mild to incapacitating. A recent national survey conducted by the Census Bureau show that as many as 10.9% of US adults who ever had COVID-19 currently report symptoms consistent with long COVID. Another study used a model to estimate at least 3 to 5 million US adults have long COVID symptoms that limits their daily activity. Next slide. As the pandemic progressed and more people had persistent symptoms, they were looking for support from the health system. They needed telehealth care, primary care, rehabilitation services, and subspecialty care. And in response to that growing need for comprehensive management of persons with PCC, medical professionals recognized the need for specialized clinics. And in these post-COVID clinics that emerged across the US, healthcare professionals had the opportunity to learn about the needs of these patients and identify what kinds of care will best support them. All this information is important for planning of care for these patients with long COVID in other kinds of settings as well. Next slide. As such, our objectives were to describe the personal characteristics of patients at PCC clinics, to outline the medical features of patients during their post-COVID follow-up, and identify how they were using care. Next slide. Now I'm going to talk about our study design and methods. We designed a study that included post-COVID clinics at 3 university health systems in 3 states: Mount Sinai Medical Center in New York, Creighton Health Institute, Creighton University in Nebraska, and University of Texas Southwestern Medical Center in Texas. These clinics were selected as they were among the first of their kind. They had also seen a large number of patients by the time this study was designed, and they were located in different geographic regions across the US. So we began collecting information on patients who had COVID between January 2020 through March of 2021. We continued to collect information on their healthcare visits through September of 2021. Healthcare professionals referred patients to these PCC clinics, but patients could also come to the clinic on their own without a referral. The study teams at each of the 3 sites collected the information from medical records. Next slide, please. Patients included in this study were 18 years or older, and they were also required to have either COVID that was confirmed by a PCR test or a health provider diagnosis even without a test between the time period that I referred to earlier, that is January 2020 and March 2021. If the patients were not hospitalized, they also had to have at least 1 visit with a health provider at least 28 days from the date of symptom onset or date of PCR diagnosis, whichever came first. If these patients were hospitalized for COVID, they had to have at least 1 visit with a healthcare provider at least 28 days from the date of their hospital discharge. Next slide. So in the next few slides, I'll highlight some of our findings. And these results will give you an idea of who was in this study, what health conditions they already had, the health problems that brought them to the clinic, the kind of care that they got, and what was ultimately diagnosed. So let's start up with describing these patients. A total of 984 participants were included in this analysis. And this table shown here has a lot of information, but I'll walk you through it. The median age of patients was 52 years, and the ages range from 18 to 89 years. About 60% of them were female, and 69% were white. A majority, about 80%, had COVID that was confirmed by a PCR test. Majority of the patients were considered to have mild to moderate COVID, as they were not hospitalized during their initial COVID illness. Next slide, please. So next, we'll review what conditions these patients already had, their pre-existing conditions. About a quarter of patients did not have any pre-existing conditions. However, when people did have these conditions before they got COVID, the most common were hypertension, obesity, smoking, sleep disorders, and asthma. Next slide. So the next two slides will give you a picture of the kind of care that these patients received. I'll walk you through this overview of patient visits at the post-COVID clinic that occurred at least 28 days after a diagnosis for non-hospitalized patients, or at least 28 days after discharge for patients that were hospitalized. Patients in our study mostly had 3 visits, and almost 30% had 5 or more visits. About 40% of patients received a prescription for rehabilitation services, and they attended multiple rehabilitation sessions, sometimes up to 50 sessions. And this information gives us an idea of the intensity of the care that was needed. Next slide. So to add to the picture of care that these patients received, they were also referred to subspecialty care. Of the 984 patients that we had in this study, 633 of them received subspecialized care. The most common subspecialty referrals were in pulmonology, cardiology, and neurology. Another notable thing is that they received care from this many different specialties, as shown on the illustration. Next slide, please. Most patients came in at least once during their follow-up with shortness of breath, post-exertional malaise, fatigue, brain fog, and headache. Starting with the physical exam, the healthcare provider collected information that helped them to support a patient. When the patient came into the clinic and a physical exam was conducted, over half of the patient did not have any abnormal findings. And this usually prompted further testing. Next slide, please. So now that we've gone over the symptoms and physical exam findings, I'll continue on to screening and diagnostic tests. Based on the patient's clinical presentation, standardized tests were used to screen for conditions like depression, anxiety, cognitive dysfunction, and sleep disorders. Not all patients were screened, but of those who were, 75% of them had an abnormal test result at least once during follow-up. Similarly, imaging tests such as chest X-rays and other diagnostic tests were prescribed. Most of the patients had problems with pulmonary function tests and chest CT scans. So of the people who got pulmonary function tests and chest CT scans done, about 80% of these patients had abnormalities at least once during their follow-up. Next slide. And finally, we'll touch on what diagnoses were ultimately given to these patients. This chart here represents the most common diagnosis by organ system during the post-COVID follow-up. Similar to the previous slide, conditions affecting the pulmonary system were more common, followed by the musculoskeletal and neurological systems. Next slide. This slide is a further breakdown of diagnosis by specific conditions, and the graph shows the 10 most common conditions that were diagnosed during post-COVID follow-up. Post-viral fatigue syndrome was the most common, with about 30% of patients being diagnosed with the condition at least once during their follow-up. Next slide. Next slide. So in conclusion, patients who attend post-COVID clinics have a wide range of symptoms and sometimes have physical exam, imaging, and other tests that are carried out. And these tests did not always give the medical professionals information to go on. We also saw that patients require high levels of care revealed by the multiple provider visits and referrals to subspecialty and rehabilitation services. And these findings highlight the need for well-coordinated care across multiple specialties and may be helpful to plan for care in other types of settings. Next slide. Thank you all.
All right, so I'm here to talk about our long COVID and fatiguing illness recovery program. Just making sure everyone can hear me.
Yes, we can hear you.
Yes.
Great, thank you. All right, next slide. So I know for this group that I don't have to go into too much background detail on long COVID, ME/CFS, and other post-infectious fatiguing illnesses, and you've heard a little bit about that already from Dr. Issa and Dr. Nji. But what I do want to briefly highlight is some of the overlap among these conditions. Long COVID, ME/CFS, and other similar conditions are complex, ill-defined, and pose similar challenges for both patients and clinicians. Some of these challenges include diagnostic challenges, such as the lack of a specific test that diagnoses these conditions, the need for consultation and coordination with multiple specialists, and the lack of evidence-based recommendations for clinical management. However, evidence does exist for the effectiveness of multidisciplinary team approaches in primary care for other complex conditions. But additional research is needed to evaluate the impact of these types of approaches for long COVID and other similar conditions. Next slide. So with this in mind, back in 2020, as the initial reports of people with long COVID were emerging, our branch published this research interest via a mechanism called a broad agency announcement titled Evaluating and Improving the Clinical Care of Individuals with Chronic Sequelae of SARS-CoV-2, Other Infections, and ME/CFS. This was a call for proposals for implementation research that would design and evaluate multidisciplinary team approaches that are most effective for caring for long COVID, ME/CFS, and other conditions, with the goal of improving the quality of life of those affected and supporting their recovery. Fortunately, these broad agency announcements aren't always tied to funding, but we were able to obtain emergency COVID response funding to be able to fund a successful proposal. Next slide. So this resulted in the development of LC and FERP, which stands for Long COVID and Fatiguing Illness Recovery Program, which was conceived as an implementation research project with collaborators that included a federally qualified health center, or FQHC for short, and academic partners. The project's objective aligned with the initial announcement in that it would evaluate a multidisciplinary team approach for the care of patients living with long COVID, other post-infectious fatiguing illnesses, and ME/CFS. Next slide. So a little bit more detail about our primary collaborator for this project. The Family Health Centers of San Diego is the main site for the project. It's one of the largest federally qualified health centers in the United States, and it includes 58 sites in San Diego County, California. They serve over 149,000 patients annually. 91% of those patients are low income, and 29% are uninsured. Next slide. The primary aims of the LC and FERP project are to improve care for the Family Health Centers of San Diego patients with long COVID and other similar conditions, to develop confidence in managing these conditions among the FQHC safety net clinic primary care clinicians, and to test the effectiveness of an ECHO model versus a traditional continuing medical education. The secondary aim is to establish a national platform for dissemination of advances in best practices in the management of long COVID and other similar conditions. Next slide. So to meet the primary aims of the study, the team is employing a randomized controlled trial approach, and this study is registered at clinicaltrials.gov. The intervention for the trial is a weekly ECHO telementoring session, specifically virtual multi-specialty case consultation and peer-to-peer sharing of emerging best practices to support case management. The control group is participating in monthly interactive webinars and quarterly short courses. The study also includes a cohort comparison where patients of the clinicians in the trial will be compared to patients at the University of Washington post-COVID clinic, which for the purposes of this study is considered the gold standard. Next slide. So if you haven't heard of Project ECHO before, ECHO in this case stands for Extension for Community Healthcare Outcomes, and it was started at the University of New Mexico. Project ECHO promotes a collaborative model of medical education and care management with 4 pillars: leveraging technology, case-based learning, sharing practices, and monitoring and evaluating outcomes. It uses video conferencing to train, advise, and support primary care clinicians. The project has previously documented increases in accessing specialty treatment in rural and underserved areas. CDC and other HHS agencies have supported a number of Project ECHO programs over the years. Next slide. So just a few more details about the intervention and control groups in the trial. The goal is to randomize 20 clinicians at the FQHC to either intervention or control arms with 10 in each arm. And 840 patients, and these are adults with electronic health record documented long COVID, other post-infectious fatiguing illness, or MECFS, and an associated decline in their health-related quality of life, who are then assigned to clinicians in the intervention or control arms with a goal of 420 in each arm. Next slide. The evaluation component involves comparing the outcomes of patients of the FQHC clinicians who receive weekly telementoring with approximately 420 adult patients being seen in the University of Washington post-COVID clinic. Investigators will also monitor how primary healthcare clinicians gain knowledge and whether they refer to specialists less often. Next slide. Clinician outcomes will be assessed by measuring change in clinical knowledge, self-efficacy, capability, uptake of specialist recommendations, and medication referrals, with these assessments taking place every 3 months for a total of 12 months. Patient outcomes will be primarily measured by change in self-reported physical function, with secondary measures of changes in severity of dyspnea, cognitive impairment, anxiety, depression, and quality of life. These assessments will also take place every 3 months for 12 months. Outcomes will also be assessed using clinic administrator, specialist, and clinician qualitative interviews. Next slide. And here's a listing of the instruments that will be used to assess patient outcomes. These include the CDC MECFS symptom inventory and the PROMIS 29 profile for physical and mental health, among others. Next slide. The methods for the secondary aim of establishing a national platform for dissemination of advances in best practices in the management of long COVID and other similar conditions employs monthly ECHO webinars and quarterly asynchronous short courses. A unique aspect of these sessions, both the monthly and the weekly sessions, are the involvement of lived experience experts, in addition to medical specialists. Next slide. To date, there have been 60 total sessions, with 15 of them being the monthly webinars and 45 weekly sessions. The weekly sessions started in December of 2021, and the first monthly webinar was held the following month in January 2022. There have been nearly 3,000 unique attendees from 40 countries in these presentations. Next slide. There have been some design and implementation challenges that have been noted along the way of getting this project off the ground. These include keeping up with the latest evidence-based advances in care as the knowledge around long COVID has been rapidly evolving, logistical and financial challenges to getting specialty care in primary care settings, and accommodating both the evaluation of both the implementation and the effectiveness of care model. Next slide. So in summary, we see the LC and FERT project as having several opportunities. First, it has the potential to raise awareness and establish legitimacy of these conditions among primary care clinicians. It provides opportunities to apply the knowledge of those who are experienced in the care of patients with ME/CFS and other post-infectious fatiguing illness to long COVID. It has the potential for advances in management of long COVID to improve management of other post-infectious fatiguing illnesses and ME/CFS. And then finally, if the intervention proves effective and scalable, it has the potential to transform care for these challenging conditions through broader implementation to advance health equity at this FQHC or other FQHCs nationwide. And actually, we've already been able to share some of the lessons learned from this project with other HHS agencies who are looking at ways to scale up this type of care model. Next slide. Thank you.
That's right. Well, thank you so much, Dr. Issa, Dr. Nji, and Dr. Cope. Thank you for excellent presentations. And I think we're going to go now to our question and answer section. So I know that there have been a lot of questions even before the webinar started. So we'll try to go through some of that, but maybe we can start with more of a general question, Dr. Unger, for you. It's been now a little over 3 years since the global pandemic started. Obviously, the idea that an infection could lead to a more chronic disease was not new to you or to our community. But 3 years later, do you see that there's a greater awareness for ME/CFS, and did long COVID really make it more diagnosable, more recognizable by the greater community? And of course, some of the programs that we talked about today, like the ECHO and those long COVID clinics, in kind of where we are today, do you think that the ME/CFS experience has helped, and did long COVID help people with ME/CFS? How do you see that?
Right. So I do think that the experience of long COVID and the sheer numbers of patients, as well as the physicians that have seen their own patients transform from healthy people to people with suffering from long COVID, has greatly increased the awareness of long COVID and similar conditions. And I think healthcare providers are much more open to learning about ME/CFS and other post-acute infectious conditions. And so we have really capitalized upon this opportunity to, at every point, bring in the lessons learned from ME/CFS to help the healthcare providers who care for patients with long COVID. And in our long COVID, the project that Dr. Cope just described, LC-FERP, we definitely suggested inclusion of healthcare providers with ME/CFS expertise, as well as patients and support organizations related to ME/CFS. At the same time, I am very hopeful and expect that the attention and the additional research being focused on long COVID will benefit patients with ME/CFS. And there is an increasing appreciation that all of these post-acute infectious syndromes perhaps are best identified or studied as a group, and focusing on what are the similarities and differences. They all are strikingly similar and all are strikingly heterogeneous, difficult to describe, and challenging for everybody involved. So I think examining together will give us a better chance for identifying true subgroups, if there are any, based on biologic differences that could be targeted through different therapies. So I think there's things are changing definitely because of long COVID.
And you mentioned this, looking at it more in a more integrated way. I know that there's an effort by the National Academies of Science and Medicine to really define a new research perspective. Is the CDC involved, and what is your view on this effort?
Right. Yes, there is a NASM workshop that will be held at the end of June. It's titled something like Steps Forward in Infection-Associated Chronic Illnesses. And CDC is one of the sponsors of this workshop. And what we do hope is that this will raise awareness among diverse researchers in the community, both various infectious disease researchers as well as MECFS and even like the dysautonomia groups, all of those POTS, those syndromes that occur following infections will have a way to begin to frame out what is the best way to work together to address the questions, and what are the best questions to address, in methods. So.
Yeah, no, that's good. I think that's really an important thing, and certainly an important outcome of obviously the tragic pandemic, that we recognize the need to do that. Maybe to switch for a moment from more research-oriented activities to the broader recognition by healthcare providers. So we talked about the LCFIRP program, but what other programs does the CDC have to assist physicians? And frankly, the public awareness for the symptoms of long COVID, the overlap with MECFS. What other ways do you have to make this be more publicly recognized?
I'd like to ask Dr. Cope to answer.
Sure. Yeah, so I can talk about, so as you already mentioned, the LCFIRP program has the monthly webinars and quarterly short courses that are open to all. And we could probably get that link and share it to make everyone aware of that if they're not already. But some of the more CDC specific, one of the other things are the COCA calls that we've been conducting. So these are clinician outreach and communication activity is what COCA stands for. And these are aimed at healthcare providers. And we've done a series of these on various long COVID topics. And we've done this in collaboration with the American Academy of Physical Medicine and Rehabilitation, which have really been one of the medical groups at the forefront of putting out some guidance around long COVID. So we've done I believe we're at 4 sessions, maybe 5, where we've highlighted different aspects of long COVID. We did a session on fatigue, cognitive symptoms. The most recent was focused on pediatrics. Long COVID in pediatric patients. So those are been reaching a couple thousand or so clinicians live, that log in at the time, and then they are available similar to your webinars. They are recorded and available online to be viewed. And Dr. Unger certainly mentioned our web content, which is, one of the more static ways we put out our information, and we're constantly reevaluating that information as well. So those are a couple ways we're trying to get the word out.
Okay. Dr. Kopp, just to clarify, so the ECHO program is open to any clinician or anyone outside of even outside of the US. Is that correct?
Yeah, this is the monthly part of it. So the intervention, the weekly part is part of the trial. So that's if you're enrolled in the trial. But the monthly and asynchronous quarterly short courses are available to all. Yes. That's
great. So we'll put that in the chat as well. I'm going to switch to some of the questions that came from the audience. One very important question, we talked about the CDC's important role in tracking data and information. This is specific to ME/CFS. Can the CDC track ME/CFS using this new code that we have now for the ICD-10? For those of you who follow this important aspect, we now have the G93.32 code. Can we use that? Is there a good way to track numbers and trends using the ICD-10 code?
Yeah, I can jump in on that again, and Dr. Unger can fill in if needed. So we agree and are pretty excited about the introduction of that new ICD-10 code. It'll be a great tool for tracking ME/CFS. And we do recognize it's going to take a little time. It takes about 2 years for new codes to really be used in a systematic way. So it's going to take some time till we can really take full advantage of it and kind of trust the data that's coming in. And we know it's going to take education. So just because we know about it we know that there's lots of healthcare providers out there who aren't aware. And so we're working on that aspect as well. And so one of the things was I was actually able to do an interview with Medscape last November, I believe, where I was able to talk about that new code. So Medscape, a platform that used by healthcare professionals to get information. And then we do continue to use our webpage as a way to get the word out. So we have information on our website. And it's something we're going to highlight for this year's upcoming ME/CFS Awareness Day. We'll be putting out information around that as well. And then also, talking about this code as well as the specific one for post-COVID conditions is going to be included in our next Medscape continuing medical education course. So definitely working on spreading the word about this new code. We're excited about it.
Just one thing to just add in addition to educating people about that there is a code, we have to really continue our education so that clinicians recognize the illness and can use the code. Because what we have found is in the past, the codes that were used for ME/CFS were, when the medical records were followed up, it often was not a case. And we know that there were many cases that weren't diagnosed. So in order for the codes to be meaningful, a lot of continued education about ME/CFS and post-COVID conditions needs to be going on. But we are doing that. So we are optimistic that we'll be able to use those codes.
Great. No, that's going to be very important, obviously, moving forward. I think we have a question for Dr. Nji. In your presentation, you shared that some of the most common symptoms that were identified in the long COVID clinics were post-exertional malaise, fatigue. This was almost 50% or 46, 47% of people had those symptoms. Obviously, these are the hallmarks of ME/CFS. I know, or it seems like you didn't ask specifically in that survey about an ME/CFS diagnosis, but is there a way maybe to estimate that? And would it be fair to say that roughly half of people in those long COVID clinics actually meet the diagnostic criteria for ME/CFS? Is that a fair statement?
Well, that's a really interesting question, because as we got this data in, we were aware of the intersection between ME/CFS and long COVID. So we wanted to look further at this data to see if those symptoms that are common to both conditions overlapped in the data. So that's something that we are currently looking at. And just off the bat, we are seeing some commonalities. It's an analysis that we're still working on. And but just as you pointed out, we do see an overlap in those ME/CFS specific conditions that are showing up with long COVID patients. And really it's important to this one of the take homes from this project will really also be to highlight that even though patients come into post-COVID clinics, they can also come in with symptoms that are very similar to those that ME/CFS patients come with, or maybe ME/CFS, full-blown ME/CFS. So clinicians really need to be aware or have a very high level of suspicion to look out for ME/CFS as a diagnosis among patients with long COVID.
Thank you.
Right, and I just want to clarify, this was a chart review. We didn't actually do a survey. And so there again, we're dependent on what the clinicians did and how they worked up and how they viewed the patients and what diagnostic codes they used. And some of the symptom-based diagnoses are very difficult to tease out of the medical record. So sometimes, in other words, the fatigue is present in many illnesses. So that certainly is not specific enough. Nonetheless, yeah, we are doing our best to try to tease out as much as we can to come close to an ME/CFS-like picture.
Okay. Well, that would be very helpful to see, the outcomes of that. And I think I can just share that from our own UNME registry. We see a similar number, and about half of people who start with COVID-19 infection after a year basically meet the diagnostic criteria for ME/CFS. So I think that, and we've seen that now in a number of studies. So that's probably at least a good estimate. Well, unfortunately, we're out of time, but this was a fascinating conversation. Dr. Unger, Dr. Issa, Dr. Nji, and Dr. Kopp, thank you so much for joining us today. We'd love to have you with us again to talk about other programs and some of the data that's going to come out of those studies and learn more about that in the coming months. So again, thank you very much for joining us today, and we hope to see you soon in one of our webinars. Carmen, if you would please lead us to the end of the webinar.
Sure. Thank you, everyone, for attending today. We just want to remind you that if you're enjoying our webinars, you can watch them on our YouTube channel. This one will be available in the coming days. And you can help make more webinars like this possible. And you can fund the next big breakthrough if you'd like to make a gift to Solve to help support our work. You can scan the donate code listed here on the screen, or you can go to solveme.org/donate. Again, thanks, everyone. Have a wonderful day.